Imagine for a second that you are the lead detective on a really high-stakes case. You've caught the culprit, you've put them away, you've basically dismantled their whole operation.
Case should be closed.
It should be close. But in this line of work, the criminals, they're notorious for breaking out, and here's the catch. They're invisible. You can't see them. You can't spot them on a camera until it's way too late. You have to rely entirely on this, like, microscopic trail of clues they leave behind.
Wow. I mean, that is a surprisingly accurate way to describe the world of thyroid cancer surveillance. A little terrifying, maybe, but yeah.
Today, we are diving deep into that exact medical mystery.
Yeah.
How do doctors know if the thyroid cancer has come back when they can't actually see it? We're looking at a stack of high-level clinical oncology material here.
The real deal.
Yeah, the kind of frameworks they use to train physicians for board exams. USMLE, that level of stuff. So this isn't some surface-level overview. We're getting the doctor's eye view.
And it really is a strategy. I love that word for it. It's not just scan the patient and hope. It's a very specific logical framework. It's a manhunt.
A manhunt. I like that. So the mission for this deep dive is to decode that strategy. We're going to look at what's called the biochemistry first rule, why trends matter more than single numbers, and the traps.
Oh yeah, the traps.
The things that even trip up medical students.
It's so important to set the stage here with the sort of central philosophy. In thyroid cancer follow-up, we do not just routinely image everyone as the first step. That surprises a lot of people.
They expect a full body scan every year or something.
Exactly. But that's just a waste of resources and it's unnecessary radiation. Instead, the blood work leads the way.
Biochemistry guides imaging. I saw that phrase over and over in the source material, so let's unpack that. If the blood work is the detective, who's the star witness, the sources all point to this one protein, thyroglobulin.
Thyroglobulin.
Why you got the smoking gun?
Well, it all comes down to its origin, where it's made. To understand the test, you have to understand the cell.
Okay.
Thyroglobulin is this big protein, and it's produced exclusively by thyroid follicular cells. Its whole day job, basically, is to be the raw material for thyroid hormones, T3 and T4.
So a healthy person walking around, like me, I have thyroglobulin in my blood right now.
You do. If we tested you, we'd find it. That's just normal physiology.
But the patients we're talking about, they're not in a normal situation.
Not at all. And that's the whole crux of the strategy. The standard treatment for high-risk differentiated thyroid cancer is a total thyroidectomy.
Taking out the whole gland.
The whole thing. And that's often followed by radioactive iodine ablation, which is basically, nuking the area to destroy any microscopic bits left behind.
So if everything went to plan, the body should be a thyroid-free zone.
Exactly. Zero thyroid cells means
Zero thyroglobulin.
the level in the blood should be undetectable, completely gone.
And that is the aha moment. It's like a zero-tolerance policy. If that protein shows up, something is making it.
Precisely. And that something can only be thyroid tissue. And since we already removed the normal thyroid, any thyroglobulin we find implies there are cancer cells. It's a tumor marker, but a really, really specific one.
So if you see that number creep up from 0 to, say, 5, you know the fugitive's back.
You know they're in the building. You just don't know which room yet.
Okay, so before we get too deep in the numbers, let's clarify who this is for. The sources are really specific about this applying to differentiated thyroid cancer. Does that mean all thyroid cancers?
No, and this is a critical point, a place where mistakes can happen. This strategy is for papillary and follicular thyroid carcinomas.
The differentiated types.
Right. Differentiated means the cancer cells still kind of act like normal thyroid cells. They still know how to make thyroglobulin.
What about the others, like medullary thyroid cancer?
Totally different beast. Medullary cancer comes from different cells, the C cells. They don't make thyroglobulin, they make calcitonin. So if you're checking thyroglobulin for a medullary patient,
You're looking for the wrong clue. You're going to miss it.
you'll miss the recurrence completely. It's also not useful for anaplastic thyroid carcinoma.
And why not for that one?
Anaplastic is so aggressive, so undifferentiated, that the cells have basically forgotten they're thyroid cells. They're so mutated, they just stop making the protein.
So rule number 1 is make sure you're tracking the right marker for the right cancer.
Absolutely. If it's papillary or follicular, thyroglobulin is your guy.
Okay. So we've got our target. We've removed the thyroid. We're looking for this protein, but the source material mentions measuring it under 2 different conditions. Suppressed and stimulated. That seems like an important detail.
It is. It's a huge one. It all ties back to the body's feedback loop. The brain sends out a signal called TSH, thyroid stimulating hormone, to tell the thyroid to get to work.
And these patients are on hormone replacement, right? Levothyroxine.
Yes, and we usually give them a slightly higher dose to keep that TSH signal really, really low. We want to suppress it.
Why?
Because TSH can act like a growth factor for cancer cells. We don't want to be poking any lingering cells and telling them to grow, so we keep them in that TSH suppressed state.
So that's their baseline, just walking around, taking their meds.
Right. And we do measure thyroglobulin then. If it's detectable while they're suppressed, that's a strong sign. But, and here's the catch, sometimes a really small recurrence is kind of sleeping.
Flying under the radar.
Exactly. It might not produce enough protein to be detected when TSH is so low. So if we really want to be sure, we do a stimulated test. We deliberately spike their TSH.
You poke the bear.
We poke the bear. We either take them off their meds for a few weeks, which feels awful, by the way, or we inject them with a synthetic TSH. That high TSH basically screams at any thyroid cells, wake up, make protein.
And suddenly a level that was 0 isn't 0 anymore.
Exactly. A previously undetectable level might pop up. The source material calls this an exam parole. Stimulated thyroglobulin is way more sensitive than suppressed. It helps us find disease that might otherwise hide.
That's fascinating. It's like a stress test for cancer cells. But here's where it gets, I don't know, really tricky. The outline mentions a plot twist. Something about antithyroglobulin antibodies.
Yes. This is the #1 exam trap and a massive clinical pitfall. About 25% of thyroid cancer patients develop these autoantibodies that actually attack the thyroglobulin.
Okay, so the body is fighting the very protein we're trying to measure.
Yeah.
How does that cause a problem for the lab test?
Well, think about how the test works. The lab assay uses its own antibodies to sort of grab onto the thyroglobulin.
Like a magnet picking up metal shavings.
Perfect analogy. But if the patient's own antibodies are already clumped all over the thyroglobulin,
The lab's magnet can't connect. It's blocked.
it's blocked. And this causes a false low or a false negative result. The lab report might say thyroglobulin 0 and everyone celebrates. But the reality is the protein is there. It's just being hidden by the antibodies.
That is terrifying. So you could think you're in remission when you're not. How do you get around that?
You have to change your tactics. The rule is when antibodies are present, the thyroglobulin number itself is unreliable. You ignore it. Instead, you start watching the antibodies.
You watch the thing that's hiding the thing you want to see.
Precisely. Because the antibodies are only there because the thyroglobulin is present. So we track the trend of the antibodies themselves over time.
So if the antibody level is going down...
That's a good sign. It means the target is likely disappearing. But if the antibody levels are rising, that becomes a surrogate marker for recurrence. It means something is producing more thyroglobulin, which is triggering the immune system.
Wow. So even when the main clue is hidden, you can follow the trail of the thing that's hiding it. That leads perfectly into the next big idea here. Trends over absolutes.
This is the golden rule of surveillance. A single number, a snapshot in time, is rarely enough to make a big decision. You have to see the movie, not just look at one photo.
The source breaks this down into 3 main scenarios. Let's walk through them. Number 1, undetectable thyroglobulin.
So that's the goal. We call that an excellent response. No evidence of disease. Those patients can relax a bit, maybe checkups once a year.
Okay. Scenario 2, detectable, but it's low and it's stable. Like, it's 1.5 this year and 1.5 next year.
That's what we call an indeterminate or biochemical incomplete response.
Yeah.
It's kind of the purgatory of thyroid cancer. The protein's there, but it isn't growing. It's just lingering.
So what do? You can't operate on a number.
You can't. If the scans are all clean,
Yeah.
you watch and wait. Active surveillance.
And the third scenario.
Rising levels. That's the red flag.
Yeah.
If it goes from 1 to 2 to 5 to 10, that suggests active growing disease. And that's when we have to act.
Which means trying to find it. This brings us to the imaging, the visuals. Back to biochemistry guides imaging.
Right. You don't just scan everyone.
Yeah.
You wait for that biochemical clue, the rising number, to tell you it's time to scan.
So the number's rising. The detective knows the criminal is in the building. What's the first door you kick down?
First line, always, is an ultrasound of the neck.
Why ultrasound? It seems so, I don't know, basic compared to an MRI or a PE scan.
It's basic, but it's brilliant. It has incredibly high sensitivity for the thyroid bed, where the gland used to be, and for the lymph nodes in the neck.
Ah, because that's where it's most likely to show up first.
Exactly. Thyroid cancer loves to recur locally first. Ultrasound can spot a suspicious lymph node that's only a few millimeters big, and bonus, no radiation.
Right. Safe, cheap, effective. But what if the ultrasound's clean? The blood says cancer, but the neck looks perfect.
Then we escalate. The next step is often a radioiodine whole-body scan. Since thyroid cells eat iodine, we give a tiny dose of radioactive iodine and see what lights up.
Makes sense. If it's thyroid cancer, it should be hungry for it.
It should be, but there's a big limitation. This only works if the cancer is still iodine avid. Sometimes, as cancer cells mutate, they lose their appetite for iodine.
So you could have a high thyroglobulin, but the iodine scan is completely negative.
Yes. We even have a name for it. Tennis syndrome. Thyroglobulin elevated, negative iodine scan. It suggests the cancer is changing, becoming less differentiated.
The notes also mention CT and MRI scans. When do they fit in?
We use those when the ultrasound is negative, but the markers are going up and we need to look deeper into the chest, maybe, or behind the windpipe where an ultrasound can't see.
Okay, but there is a huge warning in the source material about CT scans. It says, avoid iodine contrast. Why is that?
This is a classic trap. CT contrast uses a ton of cold, non-radioactive iodine. It's just a dye. But if you inject a patient with that, all their thyroid cells, including the cancer cells, just gorge themselves on it. They get completely saturated. Their iodine intake channels just shut down. So if you find the cancer on that CT scan and say, great, let's treat it with radioactive iodine next week.
The cells won't take it up. They're already full of the harmless stuff.
Exactly. You've blocked your own treatment, sometimes for months. It's a huge logistical error if you're not thinking ahead.
Wow. Okay, so finally, the heavy artillery. The PTCT scan. The notes call it the advanced sulfur.
The PTCT is really for that specific scenario we just talked about. Thyroglobulin is high, but the iodine scan is negative.
The tinnitus situation.
Right. It's what some call the flip-flop phenomenon. As thyroid cancer gets more aggressive, it often stops eating iodine and starts eating sugar glucose like crazy.
It switches its fuel source.
It does. A PT scan uses radioactive sugar. So it's designed to find that exact kind of aggressive, dedifferentiated disease that the iodine scan misses.
So we have all these tools. The final part of the material talks about dynamic risk stratification. It sounds like a fancy way of saying changing your mind about a patient.
That's a pretty good way to put it, actually.
Yeah.
It just means a patient's risk level isn't permanent. It's not a tattoo. It's a status that gets updated.
How does that work in practice?
So a patient might start out as high risk right after surgery. Big tumor, aggressive features. But if 5 years go by and their thyroglobulin is undetectable and their ultrasounds are clean, we reclassify them.
They move down to excellent response.
Right. And that changes their follow-up. We back off. We don't need to see them as often. Conversely, a low-risk patient who suddenly starts having rising thyroglobulin gets reclassified as higher risk, and we watch them more closely.
So the care is constantly being tailored to the latest data.
Dynamic, not static. That's the whole philosophy. You treat the patient based on what their biology is doing today, not just what their pathology report said 3 years ago.
Okay, this has been a ton of information. Let's lock it in with a rapid recap. I'll throw out a concept. You give me the one-line takeaway from the sources.
Let's do it.
The marker.
Thyroglobulin. But only after the thyroid is gone.
The trend.
The direction it's going matters more than any single number. Rising is the red flag.
The trap.
Antibodies. They can cause false negatives. If they're there, you have to track the antibodies themselves.
First look.
Neck ultrasound. It's the highest yield, safest first step for imaging.
The deep look.
PTCT. You use that when the blood says cancer, but the iodine scan is negative. It finds the meaner stuff.
And the overall philosophy.
Biochemistry guides imaging. Let the blood work tell you when and where to start looking.
It really is detective work, isn't it? It's about interpreting these subtle clues that change over time.
That's the whole game. And for you listening, I think the big takeaway is that this vigilance matters. The system is designed to catch things when they're just biochemical whispers, long before you'd ever feel a lump.
A very quiet, but a very effective alarm system.
And maybe one final thought to leave you with. We talked about that flip-flop cancer switching from eating iodine to eating sugar. It's just a reminder that cancer is an evolving thing. It's smart. It adapts to survive. Our surveillance has to be just as adaptable to keep up.
A constantly evolving chess match. Well, thank you for walking us through this. It really makes you appreciate the thinking that goes into every single one of those tests.
My pleasure. It's a fascinating process.
And to you, the listener, thanks for joining us on this deep dive. Hopefully the next time you hear about tumor markers, you'll picture all that detective work going on behind the scenes. We'll catch you on the next one.